Hello, anesthetists. Thank you for your hard work today managing anesthesia for patients with arrhythmias. Starting now, we're going to dive deep and thoroughly review the complex and, let's be honest, often confusing world of antiarrhythmic drugs. Here's our roadmap. We'll kick things off with the big paradigm shifts in atrial fibrillation, then move into ventricular tachycardia. After that, we'll cover the essential pharmacology you need at your fingertips, and we'll wrap it all up with practical perioperative algorithms. So let's begin with the arrhythmia we all see most frequently, AF. Right. To really get a grip on where we are with AF management today, you have to understand where we've come from. So first, we're going to explore the history and the absolute game-changing trials that have completely reshaped our entire approach. You know, the story of AF therapy is a long one, starting way back in 1785 with digitalis. But for us, the modern era is really defined by three pivotal moments. In 2001, the classification system gave us all a common language. Then in 2002, the AFIRM trial came along and completely flipped our treatment paradigm on its head. And more recently, the East AFNet 4 trial is making us rethink everything all over again. And why does this all matter so much? Well, because the sheer scale of this problem is just staggering. 15 million. That's how many patients are projected to have AF in the US alone by 2050. We're not just talking about a condition, we're talking about an epidemic, and mastering its management is absolutely essential for our day-to-day practice. And the consequences are, frankly, devastating. A 5-fold increase in the risk of stroke, a 3-fold risk of heart failure, and it doubles the risk of both dementia and death. These aren't just numbers. They're the reasons why getting our management right is so critical, especially when our patients are under the physiological stress of surgery. So a huge step forward came in 2001 with this unified classification system. It seems simple, but by defining AF based on its duration, we moved away from a clumsy one-size-fits-all approach. We started to see these categories as different stages of a disease, and that was crucial, because each stage really needs its own unique strategy. And then, in 2002, came the bombshell, the AFIRM trial. This central and honestly shocking finding is right there on the screen. The very drugs we were using to restore a normal rhythm were causing enough harm to completely wipe out any survival benefit that being in sinus rhythm provided. It was a massive wake-up call. And this slide really nails that fundamental shift. Before AFFM, the goal was almost always rhythm control. After AFFM, the whole paradigm just flipped. Rate control, using safer drugs like beta blockers simply to slow the ventricular rate, shot up to become the primary strategy for most patients. Rhythm control with its more toxic drugs was pushed back, reserved for those who were highly symptomatic. So, with that history in mind, how did this massive paradigm shift actually translate into modern practice? Let's take a look at the more nuanced strategies that we're using today for both rate and rhythm control. Now, what's absolutely key here is how cardiac function dictates our entire rate control strategy. If you look at the 2014 AHA guidance, with a preserved ejection fraction, you've got options: beta blockers, calcium channel blockers. But with a reduced EF, the game changes completely. Calcium channel blockers are out. They're contraindicated because of their negative inotropy. That leaves beta blockers is pretty much your only first-line choice. And when you look at rhythm control, the picture becomes even more restrictive. This table is a powerful demonstration of how structural heart disease dramatically narrows our options. In a structurally normal heart, you have plenty of choices. But give that patient coronary artery disease, and class IC agents like flecainide are suddenly off the table. And in heart failure, well, your options are starkly limited to amiodarone and difelikefalin. It just underscores why a really thorough preoperative cardiac assessment is paramount. So where's all this heading? Well, the future is really all about atrial selectivity. The goal is to find drugs that work specifically on the atria without the dangerous ventricular effects of the older agents. The real holy grail here is developing drugs that target channels that are only expressed in the atria. I mean, that would be a true game changer, right? It would offer us effective rhythm control without that nagging risk of proarrhythmia. And this evolving pharmacology goes hand in hand with an evolving understanding of the disease itself. We're now reframing AFib not as just a simple electrical fault, but as a progressive structural disease we call atriomyopathy. Think of it as a vicious cycle, where the AFib itself causes electrical and then structural changes in the atria that make it even more susceptible to staying in AFib. As they say, atrial fibrillation begets more atrial fibrillation. And this very concept is precisely what the recent East AFNet 4 trial validated. Now, in stark contrast to AFFIRM, which studied patients with long-established AF, this trial looked at newly diagnosed patients, and it found that an early rhythm control strategy actually improved outcomes. This suggests that for the right patient, at the right time, rhythm control is crucial to halt the progression of this atriomyopathy. Okay, let's completely shift gears now. We're moving from the atria down to the ventricles. With ventricular arrhythmias, the stakes are, of course, much higher. Our primary goal changes dramatically from symptom control and stroke prevention to the absolute prevention of sudden cardiac death. So, first things first. When it comes to preventing sudden cardiac death, the ICD is the undisputed king. Electricity is superior to pharmacology. Full stop. Our goal with drugs, therefore, isn't to replace the ICD. It's to act as an adjunct, to reduce the frequency of those nasty shocks and ultimately improve the patient's quality of life. Now, in patients who have structural heart disease, amiodarone is the clear first-line therapy. The evidence is pretty overwhelming. You've got studies like OPTIC and ALFI confirming it significantly reduces ICD shocks. And when combined with beta blockers, it also reduces arrhythmic death. But here's the key nuance. Its main role is in secondary prevention. In an acute out-of-hospital cardiac arrest, the evidence shows it may not actually improve survival over a placebo. Beyond amiodarone, SOTL is a really valuable alternative that significantly cuts down ICD shocks. But we absolutely cannot forget the cornerstone of therapy, beta blockers. As trials like Capricorn have shown, a drug like carvedilol can reduce post-MI VT and VF by a staggering 70%. They're a foundational therapy that simply must be maximized in these patients. Now let's tackle something a bit different. The specific inherited arrhythmia syndromes you might encounter. These are the rare but really important channelopathies where the drug choice is highly tailored and often completely counterintuitive if you're not familiar with the specific pathophysiology. And this table just brilliantly illustrates why getting a precise diagnosis is so critical. For Brugada, a sodium channelopathy, we reach for quinidine. For most of the potassium-based long QT syndromes, it's beta blockers. For CPVT, a calcium handling disorder, it's nadolol and flecainide. And for the re-entrant circuit of ILVT, it's verapamil. You see, each syndrome has a completely different pharmacological key.
Right. Electrical storm is a true medical emergency. It demands a rapid, systematic approach. First, correct any reversible causes, electrolytes, ischemia. Second, and this is the most critical step, you have to block the sympathetic surge with beta blockers, and ideally non-selective ones like propranolol. Then you start your amiodarone infusion. And don't forget deep sedation. It's a powerful tool in our arsenal to reduce that sympathetic tone. If all of that fails, the definitive treatment is catheter ablation.
We've covered the what and the when, so let's now dive into the how, the critical pharmacokinetic properties that govern how these drugs actually behave in our patients. This table is clinically vital. Just look at the extremes here. Amiodarone's half-life is around 53 days, while lidocaine's is just 2 hours. Or look at elimination. Sotalol is entirely cleared by the kidneys and requires a top-up after dialysis, which makes it extremely dangerous in renal failure. Understanding these parameters isn't just academic, it's absolutely essential for safe prescribing. And of course, we have to remember the active metabolites. The classic example is procainamide, a class IA agent, which gets metabolized to NAPA. Now, NAPA has pure class 3 effects, and it's cleared by the kidneys. So in renal failure, it can accumulate to toxic levels and cause torsades de pointes, an effect completely different from the parent drug. All of this brings us to the crucial need for dose adjustments. It's not trivial. In renal failure, drugs like sotalol must be aggressively dose-reduced or avoided altogether. In hepatic failure, your loading dose of lidocaine might be normal, but you have to reduce your maintenance infusion. Failing to adjust for these factors can quickly lead to toxicity. All right, let's bring it all home. We're going to synthesize all this information into practical, actionable algorithms for the arrhythmias we manage in the incredibly dynamic perioperative setting. Okay, this is the scenario that gets our hearts racing as much as the patient's. An unstable tachycardia develops intraoperatively. Perfusion is compromised. What do we do? Our immediate action is dictated entirely by this instability. The algorithm could not be clearer. Electricity first. For any unstable tachycardia, the immediate action is synchronized electrical cardioversion. Once you've restored a perfusing rhythm, then you use pharmacology, typically an IV load of amiodarone, to maintain that stability while you hunt down and treat the underlying cause. Now, let's consider the alternative. The tachycardia is rapid, yes, but the patient is stable. This buys us precious time to think, to analyze the ECG, and to choose our drugs deliberately.
The first big branch point is the QRS width. For a stable, wide, complex tachycardia, the cardinal rule is you assume it is ventricular tachycardia until proven otherwise. Treating SVT with aberrancy as if it's VT is safe. Treating VT as if it's SVT can be lethal. Therefore, your first-line agents are those that are effective for VT: intravenous amiodarone, procainamide, or lidocaine.
So, if the QRS is narrow, we know the rhythm is supraventricular. For these tachycardias, the key diagnostic and therapeutic branch point is determining if the rhythm is regular or irregular.
The next step all depends on regularity. If it's regular, you should be thinking reentrant SVT. The algorithm is simple: vagal maneuvers, then adenosine. And adenosine is key here, as it's both diagnostic and therapeutic. If it's irregular, well, it's almost certainly AFib, and your primary goal reverts to rate control with a beta blocker or diltiazem.
And let's not forget these two critical scenarios. If you see a polymorphic VT, especially one that looks like torsades to points, the first and non-negotiable step is intravenous magnesium sulfate. You give it even before you check the level. For symptomatic bradycardia, our first-line agents are the anticholinergics, atropine or glycopyrrolate. Finally, here is an absolutely indispensable tool for your practice: a quick reference for the critical IV doses of the most common antiarrhythmics we use. Having these doses at your fingertips is essential for safe and effective management in the operating room.
And this brings us to the provocative question for the future. The pendulum, as we've seen, has swung from rhythm to rate, and now it seems to be swinging back towards early rhythm control. So as we develop these truly atrial selective drugs, will we see a definitive return to a rhythm control paradigm for all new onset AF? Will targeted pharmacology finally allow us to safely halt atrial myopathy right from day one? Thank you for joining this explainer.